morning.
Shalom.
Oh, sir. I was not ready. I was not ready. Sir. Oh, my goodness. That was the laugh I needed this morning. I promise you. How you doing?
I'm good, thanks.
Ah, they ain't killing you over there in them streets, huh?
Oh,
They trying, huh?
mhm.
Like, leave my friend alone. Leave my friend alone. Okay, let's see. Let's see. Well, welcome everybody. Got people in the room. Welcome, Alina. I hope I didn't butcher your name. I'm sorry if I did. Welcome. I hear feedback. Oh, wait, I know where it's from. I know where it's from. Okay. I'm like, I hear feedback now. um, so welcome everybody to the Saturday morning tea. I still hear feedback. Why? Okay, we'll just keep pressing. Do you hear it?
Slightly.
Yeah, it's a little bitty like echo. Where is it coming from? I gotta find out. Okay, but we'll keep going. Anyway. um, welcome, welcome, welcome. On our Saturday morning tea, we discuss health information, news, education, certification tips, entrepreneurship, the weather, sports. You name it, we discuss it. Ah, I'm Clarice Warner, the Girl with the Pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And let me just ask you off the top, do you know what it takes to be a certified marketable medical coder? Do you? Probably takes more than you know. Well, before I introduce my co-host, wait a minute. Did you see the intro though? Did you peep the intro?
Yes, I did.
All right. Let me share with you um, the free 99 email course on the 5 steps to become a certified marketable medical coder.
Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder.
All right. So if you are in Clubhouse and you are interested in more information on the 5 steps to become a certified marketable medical coder, then make sure you check out the link that's pinned at the top of the page. If you are joining us via LinkedIn, Facebook, and or YouTube, you can check the video description for the link. I know it's a lot of stuff in that description, but I promise you that link is down there. But it's all resources. So check out the description. So joining me today is my illustrious co-host, Mr. Jesse, the registered trademark. Look, I was trying to find the registered trademark symbol in order to put it on the intro. I'm going to still look for it and add it.
I found it. If
Okay.
you go to, you can do it in either Microsoft Word or you can do it on. Well, I have a Mac, so they have a little the icon thing, the little emoji thing. It's in there too.
Oh, okay. Well, let me check it out over there.
If
Emoji.
you want to put it in Microsoft Word, you go to the tab symbols.
Now you're gonna make me get into Word. You know I'm an Apple girl. I don't do, but I'll look
Oh
for
well,
it.
because
But
Apple is even better because because my Mac has that bar that changes the little if they that
uh-huh.
little thing.
Yeah,
So
at the top.
it's in those
It's
symbols.
in the
Yeah, just
symbols.
keeps
All right,
yeah.
all right. I will definitely add that to because I was like, oh wait, I'm gonna put respect on his name, and I'm gonna make sure that that registered trademark is there. And I was like, okay, but I'm tired and I can't find it, and so I'm going to bed. But
I know that's
I
right.
will make sure that it is added. So, so, sir, introduce yourself and tell the folks all about you.
Good morning, everybody. My name is Jesse. I live in Philadelphia. I have been a nurse for a very, very long time. I switched into HIM in 2014, and during the pandemic, I created a company called the Coding Nurse LLC, where I help nurses and other professionals with a clinical background transition into the wonderful world of HIM.
Okay, cool. Okay, I can hear you. Maybe it was my computer. I don't know. Me and these gadgets. Cool. And how is all of that working out for you?
It is coming along.
Okay. Oh, bless you.
It's coming along fine, but my day job, baby.
Woo. Well, we have to get into that. Good morning, Vicki. Welcome. Thanks for joining. All right. Also in Clubhouse, feel free, and I guess that's everywhere. Feel free to share. Let folks know we are on and we are talking. And when I say we talking, we spilling the tea. So you can share in Clubhouse, you can share on Facebook, LinkedIn, and YouTube. So let's get into before I jump in, let me remind you that if you are on Clubhouse and you want to join in the conversation, feel free to raise your hand. Don't be shy. Hey, this is a place where your opinion matters, and of course, it is always welcomed here. Also, for my Facebook, YouTube, and LinkedIn friends, please use the chat. We really want to know what you think. When we put these topics together, we normally put them together with you in mind, and we really want to know, what are your thoughts related to the things that we bring up. So please engage with us and talk to us. It's a dialogue. It's a conversation. Also, if you have a question, please type a Q if you're using the chat first so that we know it is a question and we don't miss it. So for those who are just joining us today, we are providing an update on the nurse practitioner fight for full practice authority. And I got a little bit of information about some HIM or health information management pathways. So before we get into the main course, let me give some church announcements. So I talked before, and I failed to mention this last week, and so I want to first apologize. After we got off the call and I was talking to Mr. Jesse, I said, I forgot to tell him. So the ICD Coordination and Maintenance Committee meeting was held last week, or this past week, March 7th and 8th. And those meetings are where you have the clinical experts as well as a lot of the coding and people that are part of the cooperating parties come together, the cooperating parties who make up the information that is provided in your ICD 9 MP, or I'm sorry, ICD 9 or 10 and PCS manuals. That's a question. I know that's a test question. So those folks come together and talk about opportunities for adding or deleting or revising or revising the codes and or revising guidance. And they get together twice a year to have these conversations. And it's really, really great information. It's great for a couple of reasons. First, it's a great way to get a jump start on what's coming in the future. This particular meeting primarily focused on codes that may be added in October, because the April ones are already on the horizon. Also, there were some that were being considered for further out, so even October 24. So again, this gives you just a jump start, so and can prepare, especially if it's something in the specialty in which you code. Also, you get to hear from the experts, especially on the clinical side. They provide a lot of information. They walk you through these procedures and what they look like, why these procedures are necessary, why these ICD-10 codes are important and necessary. And they had a lot. But then you also hear from the other side of the coin, which would be the user, the people who are actually using these manuals, and you can have a voice. You can say, hey, I don't know about that. Why wouldn't you consider putting this as, I know there were a lot of questions about things, in particular procedures being added into new technology versus being surgical or medical procedures. Like, why? It's not new technology. It's just a different way to do a particular procedure. So there were a lot of comments related to that. But here's an opportunity for you to voice your comments. Now, they will let you speak. So you can say, you introduce yourself and say, and get on record. In the event of, and you don't really say you are happy with it, you can voice your comment that way. Or if it's something that you think, oh my God, we've been waiting for a code on XYZ, you can do that. I mean, and then it gets you in the record of attendance, if you will, or you are formalized in the record in perpetuity, where you had attended a particular message and your voice was heard. But even though you can do it verbally, they do recommend that you send in written comments, because they take all of those written comments and usually decide one way or the other how things are going to go. And then the biggest bonus is, of course, you get CEUs. This is a free opportunity to get CEUs, and you can get up to 32 CEUs a year. That's a lot. And how, do you ask, how can you get these 32? Well, these meetings are usually 2 days. They're 8 hours for each day. Of course, you have to keep track. And I said you can get up to 32. So it depends on how long you actually sit into the meetings. But they're 2-day events. And then they have these 2-day events twice a year. That's 32. You can get up to 32 CEUs. And that's the bomb. For free 99 CEUs. Now, what they will require is, which is genius to me, that you register. So these meetings are through, I believe CMS was the person who was doing the actual Zoom, their Zoom webinars. And so you have to register. And when they send you confirmation of your registration, that's your ticket to your CEUs. And they don't send you certificates. They don't do any of that. But that registration, you have to keep that registration as proof that, and then of course your own honest and ethical records of how long you actually listen to the call, and provide that for both the AAPC, and you can also use it for AHEMA. I'm actually going to test it out and see if I can use it for HCCA as well. That's going to be my next thing. Like, well, wait a minute, my stuff needs to hit 3 different platforms. So let me just make sure it all. So one of the things I want to talk about from that real quick, and Mr. Jesse, I'll let you jump in, is remember a long, long time ago, like when we first started having our Saturday morning tea and having our Clubhouse, we talked about hairstylists who were, and I'm gonna forget the technical name for the wigs that people were making, but they were doing it as DME providers. Because that was just enlightening to me. I stayed up, I think, all night looking for information. Like, can they do this for real? And yes, they can. Anyway, the alopecia world is on fire, and they're about to open up all kinds of ICD-10 diagnosis codes for alopecia. So be prepared. Get your hair ready. Get your products ready, because there will be a lot of opportunities for you in that space, if that's where you working from, because they have kind of specialized the differences in alopecia and the types and so on and so forth. And so they are setting the groundwork for those in that DME space to have additional opportunities and clients depending on the type of alopecia that they are documented to have. Because of course, in the DME space, you have to have a certificate of medical necessity, which would require diagnosis codes, et cetera, et cetera. So they are putting the things in play for you all to get that back. Mr. Jesse.
Where's this? So what's going on with alopecia?
They are expanding it. So there are various levels according to the clinical professionals. There are various types. There were even organizations who were on the call. I didn't even realize they have like specialty organizations for the various types of alopecia. And so they don't necessarily have all of those that was something else I'm gonna say. They don't necessarily have all of those codes for those particular types of alopecia. And so they are expanding that whole section to make sure they are including all of the various different types of alopecia that's out there. Okay. And the other thing, so we all know with ICD-10, we started to get, and I meant to look this up and I didn't, but anyway, we started to get alphanumeric codes. Alphanumeric codes, the primary purpose for the alphanumeric codes was because they were running out of spots and spaces. They're still they're seeing some changes related to that. So initially, when we were taught ICD-10, the first character was usually an alphabet. The second, third character was usually a number, so on and so forth. Well, now they're at the point where you will see letters in the fourth, I believe it's the fourth digit, which is not something that we have seen. So in certain categories, and that was some of the things that they were mentioning, like, wait a minute, where did that letter come from? Well, why is a letter there? That normally is not where a letter would go. So be mindful of these particular updates and changes that are coming in the future, the near future with ICD-10.
I think they it's not a lot, but they do have the fourth in pregnancy.
Okay.
They have a couple codes.
Well, it will be expanding in other. It'll be expanding in other areas. So don't be alarmed. Do not be alarmed when you see it, because these folks were alarmed. Like, wait a minute, hold up, time out. What is that?
A lot of times when you're in the alphabetic index, those codes will say following. So they can tell you how to find it.
Yep. So yeah, so that was all good. Then I've learned that AMA has something similar for CPT. So they have like a kind of meeting that I'm not certain that it's open to the public. I don't know if it's just for members. I didn't see that. And I mean, I didn't join that meeting, but they do put a summary of the discussion. And so they talk about, and they have, it's a real nice, cute little chart that kind of lists what the discussion was, or what they were proposing, and whether they accepted or rejected. They accept or reject right there in their meeting. Like, we're not doing that. No. Or yeah, or what. And then they also tell you an approximate time that you may see it added to the CPT book. So some of the things were coming for 2024. Some things listed were coming for 2025. Now, heads up. You heard it here first. Heads up. There is a possibility that there will be some additional revisions. I'm not certain if it's revisions to the codes or is it revisions to guidance, but there will be some additional evaluation and management. Y'all know that's my baby. There's some evaluation and management revisions on the horizons. And there also the possibility for some telemedicine specific E&M office visit codes in a year or two. Be on the lookout. It's coming down the pipe. You heard it here first. Go ahead, Mr. Jesse.
That's a lot of information, and I just find this whole coding how how it works on the back end and new codes and code development. I find it very interesting, but it really is important because this is why when you're in HIM, you have to be a lifelong learner because things are constantly changing.
Constantly.
And, like because I think about the day will come where because I had a situation this week. I have been tutoring someone who wanted to get a jump on their coding before they started their course. So we were using a book, and she was having trouble, as beginners do, using a book. So she contacted me and said that she had gotten her codified come through AAPC from her instructor. And her instructor told her, from what she said, to stop using the book and only use the encoder. So,
oh Lord,
that was my swan song because I just felt I was teach like that. In case of because like for me, like just this week, I was coding an operative, a procedure, PCS. And the doctor said that he had the doctor entered the abdominal cavity laparoscopically, but because of the number of adhesions this person had, they had to convert it to an open procedure. So in PCS, you have to, when the method when the method is converted during the operation, you have to code the initial part as inspection. So he said he entered the abdominal cavity. So when I went into the PCS book in the tab in the athletic index, I couldn't find abdominal cavity. So in PCS, they have a body parts key. So you go and look it up, and then you see what the PCS equivalent is. So the PCS equivalent of the abdominal cavity is coded to the peritoneal cavity. So I was able to then go back and figure out the code. But I don't know where that information is on an encode. I wouldn't even know where you would begin to go to look for it. That's why I don't even try. Because to this day, I use a book. I code my codes in a book, and then I put it in the encode.
Yeah. And that's a lot of, well, it's usually, it's kind of AI-ish. you kind of put information in it, or you search Google-ish, search for whatever it is that you're looking for, and then it kind of allows you or populates different pathways. But you still got to know specifics about what it is and where you're going in order to determine how to navigate that encoder. So yeah. And again, you're not tested via an encoder. There are too many different encoders out there. You're going to be tested on that book. But speaking of that book, the AAPC book, had you heard that everybody was complaining that the pages was like tissue paper?
I've only used Optum.
I only use Optum. I'm an Optum queen. So, but I've seen plenty of folks in different, I guess, groups where they've talked about like it's getting thinner and thinner, like you can see through the pages. I was like, that book won't last. If you're a book user, that book won't last. That book won't last at all. And I've never really had any problems with Optum at all. They are reliable, they're consistent, their information, I know where to go, even when I teach my classes and I have students that have different books, because I don't push one, somebody might have a preference or affinity for some other book. I just tell them to make sure they get to know the book they have or the book that they are using.
I make everybody buy.
Do you? I don't.
You know what? For me, I don't have time for. Well, my book doesn't have that. Honey, no.
And so I teach them one of our lessons is learning your book. So go through and what does your table of contents say? What's in your book? Okay, so you get to know. And don't feel some kind of way if you don't have whatever somebody else has. You have what you have in your book, and it's necessary. It's relevant to what it is that you need. Now, you have what you need to be successful for your exam. However, certain publishers, because ICD-10 is published by whoever got a pen, no, I'm kidding, by whomever. There may be some different things that they have in their book that may be helpful, either in an academic or testing environment, or may just be helpful in a work environment. So just because somebody may have something that's different than you doesn't necessarily mean it's something that you're missing out on. And I would definitely let you know, at least what's necessary, what's needed when it comes to that certification exam. So yeah, so I don't push one or the other. Oftentimes people are looking for what's more economical, if you will. For me, economics is go borrow a book from somebody else and keep it for a while, because oftentimes people are not really using their book. They have them just in case reference, but they're not necessarily using them. So ask somebody, borrow some, especially somebody who's working in a facility. They're not necessarily using, unless it's Mr. Jesse. And so he's holding on with iron gloves. He's not letting and releasing it at all. But you always need to have, I believe it's malpractice, if you will. You always need to have a manual, a book to reference. At least that's always been my thought. And I keep them for at least 5 years. I rotate them. But that's the compliance part in me, because if things go back 5 years and they want to see, well, what was there and this, that, and the third, and blah, blah, blah. So that's the purpose of that. Okay.
One more example about a book, because I'm going to hold on to a book like people hold on to all the other foods. Anyway, we were in a meeting, and there was an issue about post-COVID, and somebody having post-COVID and current COVID. So my manager, knew that I had a coding background, so she asked me, for help. So I said, we have to go to chapter 22 in the guidelines, because that covers, COVID.
Mm-hmm.
And I'm like, they don't use the book, so they don't know what chapters are in what. And when you are using an encoder, it doesn't tell you what chapters certain things are in. So she went she had the guidelines as a PDF, but didn't know where to go. They were in chapter 1. I'm like, no, you have to go to chapter 22. So in my opinion, the book will never die.
No.
So that's just me.
You're right. You're absolutely correct. I agree with that. And then the last church announcement, which kind of carries us over into one of our topics, is on the HIM pathways. So if you are a HEMA member, and you know that they have partnered with several organizations to provide professional development. And one of, if I've talked to you guys about some of the things that happened at the meeting last year, the annual meeting last year, the conference, and what we talked about a little bit in our delegates meeting. But one of them is, really helping the membership navigate this thing called health information from various perspectives. And so one point of focus is professional development. And so on March 14th it says noon Central Standard Time, but it'll be 1 p.m. Eastern Standard Time, they're having a webinar or live presentation about finding your path in health information management. And this will be a panel, I think, of 3 health information management professionals who actually started at the same place. They have the same HIM academic foundation, but they branched off into different career paths. And so they will be having a discussion or a conversation talking about the various career paths. And so if you are new to HIM, if you are looking for some transition in HIM, this may be for you. It's a free live presentation. Again, you have to register. If you are on our YouTube page, it's in the resources there. So I put the link for you to register. It's there. Unfortunately, there are no CEUs awarded for this, but there is information, valuable information. And they didn't, my only pet peeve about this is they didn't tell you what career paths they went down, because then that would have made it easier for people to kind of decide whether it's something that they may want to invest their time in. But just wanted to give you that information. Mr. Jesse, did you have anything you want to add to that? Okay. All right. So let's get into the other topic we have today, and that is talking about our friends across the aisle, nurses and in particular nurse practitioner, and this fight that they seem to be having on all fronts, particularly one particular aggressor, the AMA and physicians, on nurse practitioners and being able to have full practice authority so that they can actually provide services to the needed populations across our country without physician oversight. You want to jump in first? You want me to? What you want to do?
Take it away. I'll jump in later.
Okay. So there is one particular article that I know I pinned in our thing. Let me see. I'll show this. I'll show the screenshot. Share screen. Okay. So in this particular article, it gives you some states where nurse practitioners can open up their own practice. So if you or somebody you know is a nurse practitioner and looking to have full practice authority, here are some states that happens. Now, full practice authority, let's talk about that, because I think so there's several types of authority that is going down. First one is full practice authority. And so under full practice authority laws, a nurse practitioner can prescribe, diagnose, and treat patients without physician oversight or supervision. Nurse practitioners in these particular states can practice independently, including operating their own practice. You also have what's called reduced practice authority. And in these situations, a nurse practitioner can diagnose and treat patients, but require physician oversight to prescribe medications. And lastly, you have restricted practice authority. And it says a nurse practitioner must have physician supervision or oversight to prescribe, diagnose, and treat patients. There are several legal and legislative restrictions on practice authority. So in this particular article, who wrote this article? By the Nurse Journal staff. They mentioned that there's data that demonstrate that nurse practitioners offer excellent primary and specialty care, whether it's offered under physician oversight or independently. And another thing I saw in this article, or maybe it's in another article. No, how the growth projections for nurse practitioners will grow by at least 46% from 2020. Well, it was 13% from 2021 through 2023. Just overall growth in the healthcare field. But for nurse practitioners, it's expected to kind of balloon just out the wazoo. And then it says the growth is fueled in part by physician shortages, excellent patient outcomes, and an aging population with greater health needs. And nurse practitioners who work in full practice authority states can offer a greater range of services and options to patients. So here are the states. There are 26 in the blue. Uh-oh. Let me get out of here. Okay. The blue ones are full practice authority. The purple ones are reduced practice authority, and the dark blue ones are they probably should be black, but the dark blue ones are restricted practice authority. Now, we have talked about the fight with nurse practitioners that has been happening across the country. Now, they do have 26 full practice authority states. There are 13 reduced and 11 restricted. But again, there's been a push and a move to get more of these full practice authority states recognized and get the nurses over to full practice authority in these states. We always talk about the big states. The big states are California, Texas, Florida, New York. Who else is a big state? We have 5. California, Texas, Florida, New York. Who am I missing?
I don't know, but if I would pick one, I would say because of all of the current changes and a lot of medical hubs relocated to this area, I think Tennessee is another one. Because there's a lot of healthcare companies that relocated to Tennessee.
Okay.
For a couple of years. I don't know why, but for taxes, that's why.
Oh, well, look, you know where the money reside. Where the money reside. Okay, so and all of them except one, New York, is actually a full practice authority.
And
they just became, and so that's why there's a lot of attention and a lot of eyes going on to see what's happening with some of these other states. And then in this article, again, I linked the article. They give some additional information if you or someone you know who is a nurse practitioner and looking to open your own practice. Gives you some information there. Now, the other thing is with these particular states, we've learned that Texas is now looking to do some things with nurse practitioners, and I was kind of shocked, but there's there may be some kind of good news coming out of Texas. So State Senator Cesar Blanco and Senate filed Senate Bill 1700, which is the Healthcare Expanded and Access Locally, or HEAL Texans Act. And this bill expands health access by allowing full practice authority for nurse practitioners in Texas. There was a press conference, and this article is by Mark Hollis. I don't know where this article sits, but it's written by Mark Hollis. And so they were announcing this bill, and they said currently the advanced practice registered nurses comprise almost half of the primary care workforce in Texas. And they believe this can help expand healthcare access and options for Texans close to their home. One of the things that they hear a lot is that about the healthcare professions shortage, and folks have to travel. They can't get care. They don't have access to care. They hear the senior citizens say Texas is a great place to retire, but a bad place to grow old. And that was a quote. And so this would be huge if the Heal Texans Act comes to pass and passes. Thoughts on that one?
Oh, it would be a game changer because if you look at that map, there are no states in the South that are full practice authorities. None.
Mm-hmm.
So, and I mean, even me, like I cannot appreciate just the size of Texas. Texas is huge.
Huge. I've been there.
And I can imagine there are lots and lots of areas that could really benefit from a full practice nurse practitioner as opposed to having to drive quite a distance to a physician's office. And it would just be a game changer. And I really do think it's going to happen because I think it has to happen because also I think what is prompting this is probably is also COVID because during COVID so many people moved to Texas and a lot of older people moved to Texas. So I just think that it's just a convergence of a lot of different things, and I just think that it's just long overdue. Like I don't. I mean, I see nurse practitioners privately. I mean, as you know, who control my health.
Mm-hmm.
So I don't have an issue. And even when I was in the hospital, I saw doctors and nurse practitioners. I don't have an issue. There's no, and I know people personally who don't feel as though a nurse practitioner could treat them, and that's their opinion. But I don't see an issue. I hope that it goes through. It should really be across the board.
I agree. I've had nurse practitioners. I've been under the care of nurse practitioners, and I think they're wonderful. They're great. I haven't had any problems with any of the information that they've provided to me. I haven't had any concerns. I feel like the nurse practitioners that I've dealt with have great bedside manner. To me, most people, at least I associate, I can speak for most people. Let me speak for me. For me, I associate care, true care, with nursing, because nurses are there, and so through the various experience that nurse practitioners have, because you can't just decide, oh my God, I just want to be a nurse practitioner. No, you have had to go through the trenches. You have to, there's a lot of work and experience that um, happens with nurse practitioners. And oftentimes they have been bedside nurses. They have been nurses who have built up that clinical acumen and know about from which they speak. And most of them, while there are a lot that are general practitioners or family practice nurse practitioners, a lot of them specialize in particular areas. And they are interested in diabetes care and management. They're interested in hypertension. I know some that are interested in HIV. So there's a lot of times they're specializing under that umbrella in certain areas. And for always, I believe if you specialize in the area, that's where that's your focus. You know that inside and out, oftentimes. And so I am really, really excited that this has come to pass. Even though, and I found another article that's kind of spoke to even though they have like the 3 areas, it's still fragmented. There's still some different things that you got to dig into. So if you are a nurse practitioner or someone you know who is working as a nurse practitioner or you work with them, just make sure that you go to that state board of nursing to find out the specifics of what is happening with nurse practitioners in that particular state, because they would know, because some of them, so this article, and it's really for a university, I guess, but the article is fabulous. They there's actually more states that have full practice authority. They just have it broken down in two different categories, if you will. So there's some additional components to that full practice authority. So for example, there's some states that have full practice authority with the initial license. So you don't have any other stuff that you got to do or hoops that you got to go through in order to do it. Alaska is one. Their nurse practitioners have the ability to prescribe all class controlled substances. Their prescriptive authority for the controlled substances is a separate application, but they have the ability to do all of that. Arizona is another one. They have full prescriptive authority. Prior to prescribing medications, they must submit a controlled substance prescription monitoring program application. So there may be some additional steps to take, but they do have full prescriptive authority. Delaware is another one. Hawaii is another one. They do require, prior to prescribing medications, that the nurse practitioners take advanced coursework in pharmacology. Idaho also is another one. They have also partnered with Wyoming to allow nurse practitioners to work in both states under a single license. To earn prescriptive authority, they must complete 30 hours of qualifying continuing education courses. Iowa, nurses can treat, diagnose, and prescribe independently. There's a separate application that they need for controlled substance registration and to be authorized by the DEA. Maryland, they can practice independently. There's no provisional period. However, in an attempt to curb opioid use, nurse practitioners who prescribe narcotics must register with the state's prescription drug monitoring program. Montana, another full practice state. They must be board certified and have graduated from an accredited nurse practitioner program that has included a preceptorship. Nebraska, same thing. They must complete 10 hours of pharmacology, continuing education every 2 years to maintain prescriptive authority. And then they must have an active DEA registration to schedule drugs. Nevada, same thing. New Hampshire is good. New Mexico, North Dakota, Oregon, Rhode Island, South Dakota, Washington State, DC, Wyoming. And then the next group is they offer full practice authority, but it's after a provisional period. So there's some kind of additional hours that they have. So Arkansas, they have full practice authority, but the nurse practitioners have to have completed at least 6,240 hours of a collaborative practice agreement in order to apply for full practice authority. In California, they have a 2020 state law that creates a pathway to full practice authority that supposedly took place in 2023. So nurse practitioners with 3 years of experience can work without a collaborative physician agreement in select medical facilities. They also are working on Assembly Bill 890, which offers full practice authority across all clinical settings by 2026. Colorado also has the provision of completing 1,000 hours of practice with provisional prescriptive authority. Connecticut and Colorado are the same. Florida, licensed nurse practitioners with at least 3,000 supervised practice hours can lead primary care practices without collaborative agreements. State law requires nurse practitioners to complete graduate courses in differential diagnosis and pharmacology before independent practice. Illinois is another one. And they must have at least 4,000 hours of supervised experience following national certification for full practice authority. Kansas approved a change to their nursing licenses in 2022, eliminating prescribing protocol and collaborative agreement requirements for nurse practitioners. It requires them to hold malpractice insurance and maintain national certification. There is some ambiguities going on, and so they're still trying to figure out the legal distinctions between medical and nursing services. So they're battling in Kansas. Maine requires advanced practice nursing specialties to have 24 months of supervision before applying for independence. The nurse practitioners may prescribe medications in addition to diagnosing and treating conditions. Massachusetts became the 23rd state to authorize. They can do so, apply for full practice authority after completing 2 years of qualified supervised practice. Minnesota, any nurse practitioner that began their practice after July 1st, 2014, work in a collaborative agreement for at least 2,080 hours prior to being granted the full practice authority. New York, they also created full practice authority for nurse practitioners with 3,600 practice hours or more. Newly licensed nurse practitioners can work with experienced nurse practitioners or physicians to complete their practice hour requirement. Utah amended their restrictions. Nurse practitioners previously required consultation and referral agreements with physicians in their first year or 2,000 practice hours. House Bill 287 supports full practice authority once nurse practitioners complete 1,000 hours of informal mentorship by physicians. Vermont, they still must enter into a collaborative agreement with a physician or a nurse practitioner for 2 years or a minimum of 2,400 hours prior to obtaining full practice authority. Virginia had a state law that took effect in July of 2022, creating full practice authority opportunities. Licensed nurse practitioners with at least 5 years of clinical experience can apply through the State Board of Nursing. And then we showed all of the reduced practice authority states. So there's some that are kind of full practice with some conditions. So the actual number of full practice authority states is actually still growing. I was glad to see, and to your point, that this is going to happen. You saw where Florida was one that has been added, California. So our big states. I didn't see Tennessee. What's going on in Tennessee? Some of our big states. It says supervising physicians are required to review 20% of patient charts from nurse practitioners every month. There are additional review requirements when nurse practitioner prescribe controlled substances or upon patient request. So they still got some work to do down there in Tennessee. But yeah, I think it's great. This article actually came out before the press conference in Texas. So right now, they're still in Texas are required to have a collaborative agreement and prescriptive authority requirements in place for nurse practitioners in Texas. Ooh, and then it also says they hit them in the pocket. Collaborative agreements may establish fees paid by nurse practitioners to supervising physicians. They try to get paid. Wow, that's shady. That's shady right there. But yeah.
That was going on during COVID with those clear labs.
Really?
Yeah, they were. I mean, those.
Well, they were setting up those arrangements to have those physician oversights. Yeah.
They were for money. I saw them advertised.
Wow. So what are your thoughts? People either in the room or listening in, what are your thoughts as it relates to nurse practitioners? Do you think that nurse practitioners should have full practice authority? Do you live in a state where the battle is on and it's hot and heavy where they don't have it? Or do you live in a state where they do? And do you have any experiences one way or another? I am really, really curious to know where you land with that. So please, you can place your information in the comments. If you are in Clubhouse and you want to speak, please, by all means, raise your hand. We'll definitely bring you to the stage to have conversation. And Mr. Jesse, I'll let you weigh in.
It's going to happen. I think that it's great, and I'm all for it. I always have been, because like this whole, I don't know. I mean, we all know the role that physicians play in healthcare. We all know. I mean, we all grew up going to doctors, but just the implication that care could somehow be compromised because nurse practitioners are on the scene, I just really don't agree with. And being in healthcare as long as I've been in healthcare, I remember when in New Jersey, before they moved to e-prescribing, they were out of control with their controlled substances, so much so that the state issued prescription pads. You had to get providers had to get their prescription pads from the state.
Wow.
They didn't have them printed up on their own, and they were numbered, so they could track how many prescriptions you wrote for this type of class of drug.
Wow.
So don't, I'm not. I mean, I've been around for a long time, so I'm not trying to hear foolishness because these doctors, like they complain about oversight, but they're the reason for oversight. They have stolen and done all kinds. They have robbed this country of probably over the course of the time I've been a nurse, trillions of dollars in money, because it's billions annually. And then you get mad when somebody comes along and offers an alternative. I don't get it. I'm just over the whole thing.
And I feel like ultimately it should really be about providing access to care to everybody. And physicians are aging out. The demand is great for physicians. There has been data that's shown physicians, there are certain areas physicians don't want to go. Certain people they don't want to treat. Certain folks they don't want to see. But just because the physician chooses not to see, treat, or deal with certain classes or categories of patients does not mean that patient doesn't have a right to access to care. And so if there is someone who is interested and passionate about seeing and treating and providing equitable healthcare to folks, then why not support that? The fight against that is just, that's a lot. And so I'm all pro full practice authority. I believe that nurses have earned their place to do that. I see where there are other professions that are allowed to open up shop in a medical capacity. I don't understand why they should not. And I mean, I do agree they should have, malpractice insurance. I mean, they need to have all of the things in play. I'm totally support that. From a health information and compliance professional perspective, I believe there are opportunities for anyone in revenue cycle. I believe this allows or expands the opportunities for our profession to assist with these new practices. There's only so many hospitals that folks can work in. There are only so many doctors' offices that can work in. So this expands that that area as well. So I think it's a win-win for us. Yeah, I just really I think from a compliance perspective, I think nurse practitioners need to be prepared. I think they need to understand. I think most of them probably know, especially if they've worked with providers and kind of know what happens. I think I mean, they need to be prepared as far as the scrutiny as it relates to their documentation and understanding all of that. So I think there's still maybe a knowledge gap there, because we see it with providers or physicians anyway. So there may be some sort of knowledge gap, just making sure and ensuring that they provide all the necessary information. But nursing usually has much better documentation, if you will, than physicians. So it may not be a huge gap, but I think, just understanding some things that occur as it relates to the entire revenue cycle and, the payer and reimbursement aspects, and understanding what that looks like and what happens. And so I think there may be some opportunities there for providing information. But I don't see why they just won't let them do it. I don't understand. I mean, the fight, like.
I also think that there's going to be another fight in the coming years, because it's already kind of low key happening. Because there are a lot of nurses who are getting their PhDs now, and there's a debate about whether they should be called doctors in the clinical space. And I think that's I don't know. Well, even me, I'm kind of perplexed, because the term doctor is synonymous in a clinical setting with a medical doctor.
Correct.
It is.
It is.
When you're in an academic area and somebody's called doctor, it's academic.
Correct.
You're not getting that confused.
Right.
But in a clinical setting, I can see completely how that would be confusing. And I don't know how you handle it, because if you completed your PhD, you should be able to use that title. That's why you got it. So I don't know what the workaround could be for that, but that I see as the next hill.
That's interesting. Yeah. So will they just become? Will they call doctor, nurse, or? But most of them are not necessarily. Are they working in the clinically? In the.
They're not academic.
They're actually like seeing patients or practicing nursing.
No. Like for instance, there are a lot of nurses that have master's degrees.
Yes.
They don't necessarily have them. They're not NPs. They have it in nursing education. They have it in nursing leadership. So if you have a PhD in nursing leadership and you're working in a hospital and somebody calls you, doctor so-and-so, they're not going to say that. I think maybe the workaround, but then even that gets to be too long. Nobody's going to call you a doctor in nursing leadership, Joe.
PhD Dr. Jones.
So it gets,
That's interesting.
Well, maybe that could be. Maybe instead of you have to be called PhD instead of doctor in the clinical setting. Maybe. Because that still recognizes the title.
Right. And some PhD folks or EDD or folks who have received that terminal degree, trust and believe, there are a lot of them out there. Please refer to me as doctor. Be like, oh my God, I knew you when you was 11 years old. You would, whatever. They want you to put some respect on their name. RESPECT. That our song for the day.
They have all those sleepless nights and that student loan balance. I want no part of it.
Oh, that's the truth. Now that right there, that's the truth. That is the truth. She said, we got a comment. Make no mistake and don't forget it. All right now.
I think that's going to be the next issue. So, they'll work it out. They'll come up with something.
Interesting. I can see. I mean, I'm remembering being in boardrooms or being in meetings with various entities at the table, and so say you have your VP of nursing or your chief nursing officer, but they are Dr. so and so who is the chief nursing officer, and then you got I can see some battles happening there, just in those small rooms and conversations. That's funny, because folks do get in their feelings about their titles. And rightly so, I guess.
I'm not begrudging.
Yeah, and rightly so.
That's not my issue. My issue is to get what you earned it. I'm gonna call. I don't have a problem. Respect costs nothing.
That's right.
But I'm just thinking about in a clinical setting how that could ultimately be confusing.
Yeah. Yeah. That's true. So, especially with patients. I mean, even with patients, like, well, Dr. Jones said, well, who is that? We don't have a Dr. Jones in here. Well, that one right there, that's Dr. And it's like, oh, she a nurse or he a nurse.
We have a question in the chat on Clubhouse from Molly Picasso.
Okay.
Quick question for you guys that are coders. Do you know any remote companies hiring? That's a broad question. Like, what's your specialty? How much experience do you have? What do you want to do? That's a lot more. You gotta have a deeper dive into that.
Mm-hmm. Because there are. I saw something. Where did I see? I saw something recently that was even talking about. Oh, it was about HCC coding. Somebody is doing something on. There's a webinar. Somebody is doing something on HCC coding and asking people who are interested. And then there was someone who was providing additional information about organizations that are looking for HCC coding. He says, sorry, it was very noisy where I am. Okay, well, if you could provide us some additional information, yes, there are opportunities out there from folks to
I used to really be pro risk adjustment coding, but well, Amami Picasso said, I have my CPC, I have over 5 years ED multi-specialty experience. That should be no problem. I think if you're not on LinkedIn, I would just put your resume and create a LinkedIn profile, and people will hit you up all day long.
Mm-hmm. They will come to you.
Yes, there are all kinds of companies, especially for ED. I have a lot of recruiters reaching out to me that the assessment tests are horrible. That's just the nature of the business.
Yeah, they do that. You have to be prepared for that. That's been going on for years.
There are companies I've applied to. When my first question is when they say an assessment, how many questions is it? I'm not answering those 60-question assessments. No, I'm not doing it. So when they tell me, I'm like, oh, no, thank you. It's not necessary.
It's not. What's your maximum question length for an assessment?
Ideally, not 25. Because if you know what you're doing and you have a certain specialty, those 25 questions, you can get in everything you need to know.
Yep. And if they crafted those assessments properly, they can ask everything they need to know in probably less than that. But absolutely. Yeah. It's like I had one yesterday that took me over 3 hours. I felt like I was getting another certification. Yeah, that's foolishness. That was foolishness.
I had one assessment for an inpatient coder job. They the time limit was 8 hours. Who's doing it?
Oh my God.
Not
Who is doing that? Yeah.
And then there's some companies that don't give a test at all.
True.
But what I have found is when you work if you're trying to be contacted by an agency will definitely give you a test. I found that companies give you better assessments. They're not as long and they're more focused. Like these recruiters and these agencies, they're on some straight BS. But I think you would have better luck if you apply to a company or to an institution directly.
Directly. Yeah. Yeah. I agree.
Try Indeed and Glassdoor and apply directly. Because an agency or an outside company is definitely going to give you an assessment.
She also said, always put in Coder Remote USA. They are out there. They will find you, honestly, especially in the Midwest area. Yeah. So they're out there. And again, with your years of experience and certification, you should be good.
Definitely.
Should be good. All right, sir. We are at the top of the hour.
Yes.
We got some information out there to the people. A lot of information out there to the people. Some that benefits others more than the rest, but I think some it's sprinkled all the way through. So this has been a great session. Thank you all again for joining the Saturday morning tea. Let me ask, was the tea spilled today? Was it spilled today?
Today and every Saturday that we can and mic up.
That's right. Ah, cool. So if this information was valuable for you, and don't forget to answer the questions about nurse practitioners. I am really interested in Shay says her job is hiring. SanfordHealth.org remote.
I work for them remotely. They're based in South Dakota.
Okay.
I worked for them briefly, and they did have this. And matter of fact, for my job, it was home health coding. They had an assessment. It was only like 5 questions.
Oh well.
They were kind of detailed, but 5 questions.
All right, Shay.
And with them, you had to take the test live.
Oh, okay.
Like literally, like you could turn your camera off, but you had to leave your volume on. And the interviewer was, doing whatever she was doing, but you had to be connected. I guess so they could see if you actually were taking a test and you didn't have somebody helping.
Wow. For 5 questions though?
Yeah.
Oh, she said the assessment was 20 questions and it was easy. Okay.
Oh, good.
Cool. Well, there you go. SanfordHealth.org. Remote coders. All types of coders, Shay, or just anything in specifically? All types. All right. There's information. Look at us spilling additional tea, trying to get out the door and spilling tea on the way out. That's the beauty of networking. Yes. Thank you, Shay, for providing that information. Thank you also, Renita, for being here and providing information as well. It is helpful. Again, this is a conversation. Yes, you did. This is a conversation. And for us all. So we are all walking away with some additional knowledge that we didn't have when we walked in. So yes.
One more piece of advice for Money Picasso. Anybody that is looking for a job, especially if you have an AAPC certification, get involved with your local chapter.
Yes.
That is when I tell you those women know people who know people. You have got That's key.
That's key. Get involved and give some time. Come out to the meetings, or if they're still having virtual meetings, join the virtual meetings and network and get to know folks. Because I've told people for years, oftentimes we know about what's going on in the job force before it's even published. Somebody will make an announcement, hey, we looking for XYZ. And if I know you and they know you, and then we have these conversations, let me tell you who you need to slide your information to. Let me tell you where you need to go. So you are absolutely correct. It is all about networking and getting to know those people. Now, if you're looking remotely across the country, then you may need to tap into some of the AAPC locations there, and they will be able to help you. And then, if they recognize your name or recognize you, or you've been given some valuable information for folks, then they will take all of that in consideration. Hey, so and so and so, they have been helpful for this and helpful for that. Let me see, if I can slide their information, or if they are a good fit for XYZ. So yeah, it's all about, that networking and getting to know folks, like we do here every Saturday morning.
Because like my local AAPC chapter, I haven't attended a meeting in a while, but they have when they have their meetings, it's 160 people.
Mm-hmm. Ours have been still virtual lately, but we get them in, and
That's a lot of opportunities.
There's a lot of opportunities. And then there's opportunities for you to even, like I said, volunteer, because every year they're looking for people to be on the board and to assist. And so this is also a way for you to network and serve locally with your chapter.
Actually, I need to probably do another presentation. I did a presentation a couple of years ago for my chapter, and it was about how I did it on how the low carb diet can help your productivity. And there's actually, I'm not going to get into it, but I did a presentation. It was about an hour.
Yeah, and if you're interested in having that's your first introduction to the TED Talk world. I mean, you want to get your feet out there, you want to provide information, you want to present. Here's another training ground. It's additional training opportunities for you to do that amongst your peers.
Definitely, because the local chapters are looking for information. They want people to bring new things too. Because it's all about education. It's all about, informing each other about what's going on, and you never know how it can help you.
That's right. And you get CEUs for producing the content, and you get CEUs for being there getting the content. So yes. All righty. So again, if there's information that was valuable for you, help us share this message with others by liking the video, sharing the video, and subscribing to the channel. You can also check out the Coding Nurse channel on YouTube. Last but certainly not least, to my Clubhouse folks, click on the greenhouse to join in the fun in our club, and you will get notified of our live broadcast, which usually happens on Saturday morning at 9 a.m. Eastern Standard Time. Again, this has been a great session today. I'm glad that we saw some new faces and folks didn't feel shy coming and asking their questions and providing feedback. We appreciate it. That gives us additional, because Lord knows we probably can talk all day, but that gives us additional, this is a lot to talk about, but that gives us additional information and understanding and allows us to bring value to you every week. So thank you all for being here. Again, remember that you need to be safe, be kind, and don't wish for it, work for it. Until next week, make it a great weekend. Bye-bye.
Can we chat backstage?
We can.